make sure we're streaming before I start my yapping. Truly think it's very cool that you are in my neck of the woods. It's such a good facility, a good institution. All right. Looks like there's people here. YouTube is popping off. Okay. There we go. We are live. The people are entering the room, so let's not keep them waiting any longer. Let's start the show. Hello, everyone. Welcome back to Luncheon with the Experts, a Carcinoid Cancer Foundation and Neuroendocrine Cancer Foundation, formerly known as LACNET's program. My name is Rain Bennett. I am your host this episode and every episode, and I am a filmmaker and a writer by trade. I've been working with both of these organizations, primarily CCF, for over a decade now, folks. My introduction to Keith Warner and Grace Goldstein was in 2011. I was living in New York at the time, and in 2012 we did our first video series, and in that decade plus we have done hundreds, maybe 1,000 videos since then. Treatment-based videos, human-centric patient documentaries, live video Q&A sessions like the one you'll watch today, but all with one mission in mind, and that is to spread awareness and education about neuroendocrine tumors. That is what we are here to do. Now, if you are new to this journey, if you are new to the show, I want to say welcome, first of all, and you might already see people in the comment section saying hello, where they're signing on from. I always encourage people to say that, one, for selfish reasons, because I like to see how far the program reaches. Every week, inevitably, we have people from like places where they should be going to bed, but they're tuning into the show. So you know what that tells me? It tells me we do a good job and we have excellent guests on the show. But also, what it does for you is, in that decade, what I've noticed about this community, this NET community, which includes patients, includes specialists and doctors like our guest today, includes caregivers and support group leaders, it is so incredibly strong, so incredibly supportive. So I say all this to say, embrace that community, introduce yourself. You will learn so much from their shared experiences and shared stories, and they will share them with you, that it will continue to help you along this journey. So embrace the community. I assure you it will embrace you back. It's been one of the things I'm most grateful about being tangentially a part of this community, is seeing the strength of that. So go ahead and say hello, tell us where you're from. And in the meantime, I'd like to welcome back to the show for I don't know how many times it's been, but Dr. Diane Reidy-Lagunes. Dr. Reidy, how are you? Welcome back.
I am great. And I have to say, I'm like getting emotional seeing all these names. I miss you all so much.
You see
like
them?
all my people are on this, and I'm like literally tearing up seeing the names. So thank you all for coming on. And it's absolutely a tremendous pleasure and honor to be on again, Rain. I love that you invited me back.
Yeah, absolutely. I was telling Dr. Reidy beforehand that we need to implement like Saturday Night Live. Every time you've hosted 5 times, you get a special like jacket. I think we need to start doing that and get the Luncheon with the Experts, patch on there, the little crest. Honestly, seeing the comments of people saying that's kind of what I was alluding to in the intro there about the community. It's such, hopefully a long-term journey if we catch it and diagnose it in time, that you really form these bonds with your patients. I'm not saying that doesn't exist in other diseases, but I see it personally very strongly in this overall community, and it's reflected right there in the comment section. Everybody does miss you, but sorry to say, not sorry, that she is now in the great state of North Carolina. Tell us where you are. Tell us your new mission and your new institution.
I am in the great state of North Carolina. I am still bleeding blue because I came from MSK that was blue, and now I'm at Duke. So anyone in North Carolina or in the Southeast, we would be absolutely honored to have you. We're very, very excited to build the neuroendocrine tumor program down here as a center of excellence. And, Rain, what you said is so true. I mean, I think as many of my patients that are on the call know, it's such a gift for me to have these relationships with patients for so long, but I have such a tremendous responsibility to make sure that we're always kind of focused on quality and quantity, because thank heavens our patients can live for so long. And so it's a big job. And like you said, like it gets hard when we care for other diseases and patients pass from the disease. our patients, thank heavens, can live longer, but they're still terrible diseases, and we have to be very careful and mindful of how we treat and when we treat. Like you said, it's just such an amazing community to be a part of. And so now we're taking that community down here to North Carolina and the great Duke University. So I am the Division Chief of Medical Oncology here. So I oversee the medical oncology program, and we're super excited in that we're also growing throughout North Carolina. So there's lots of clinics that we're actually growing as North Carolina and the state population grows to not only grow Duke, but more importantly, grow specialized cancer care, as you and I were talking about before. Sometimes in the rural communities that aren't, right next door to a cancer center, it can be incredibly challenging to find the right docs that know these types of diseases. And so we're leveraging telehealth and these different clinics to make sure that we're bringing this specialty care to the folks.
Yeah, absolutely. And you kind of bring up indirectly another point there that I think contributes to the strength of that relationship is that a patient, and I deal with this all the time, or I learn about this all the time through the patient documentaries that we do. Often patients go through a whole list of doctors before they get an accurate diagnosis. And I assume that when they find that person, it's like, I know what this is. I know what to do. I got you. That's got to feel so comforting, and it probably contributes to that attachment, that connection that's established. I am making an assumption there, but I've heard these stories over and over again. So I think that probably is part of it.
Absolutely. And then that you got a plan, right? So now you've gotten this, in some ways, I can't tell you how many times I've heard patients pay, well, thank heavens, at least I have a diagnosis because it's so long to get. But then equally, if not more important, is okay, what's my plan and what are we doing? And then why? How can hopefully your team explain to you what the plan is, what you're going to expect, and what that follow-up is.
Absolutely. Folks, go ahead and start sending in your questions, a little bit of best practices and some tips for you. In that vein is it's very hard for us to field super case-specific questions in this format, right? So the best way to get the maximum value is to ask short, generic chunks. There is no limit to how many questions you can ask, so you can always ask follow-up questions as the show goes on, but that really helps those little bites, kind of like a trail of breadcrumbs, and it will probably open the door to another question. That's perfectly fine. If we don't get to your question today, a reminder that we always have ncf.net/support line. You can always reach out there and someone will field your question and hopefully give you some guidance or direction to whomever could give you the answers to those questions. So you've always got that resource as well. So go ahead and start sending in your questions. We're going to try to get to every one of them and move along quickly. I also want to say, we talked about Dr. Reidy being here several times, that this week, almost this date, because what's today, the 10th? Is the anniversary of the 5th anniversary of the show. I was looking up our archive videos and episodes, and it was, I think, July 7th or July 9th of 2020 when this show started. And you can imagine why. With that year, it was in the middle of the pandemic. We weren't doing things in person, and so that was kind of the catalyst or the impetus to start the show. And here we are 5 years later, and that's because of great folks like Dr. Reidy and also the great audience members that keep coming back every week. So thank you so much for being here. I can't believe it's been 5 years. It's super exciting. I love doing it. Yeah, it's awesome. It's awesome. It says a lot. It says a lot about you all, and it says, I'm proud to say it says a lot about the show as well. Okay. Speaking of which, let's start the show. We've got Ruby, a friend of the show. Hey, Ruby, I missed the last show because I was in the hospital with another blockage, and it may now have to have part of my colon removed. The question is, how common is this for us NET patients?
That's a great question, and I'm so sorry to hear that news. I hope you're recovering okay and that you're doing well. I think there's a big kind of debate, if you will, about removing primaries and or the risk of obstructions. And there's two reasons why our patients may have a blockage. One is that the primary tumor that's inside the small intestine or the large intestine can sort of impinge enough on the inside of the tube, if you will, and cause a blockage. A second, and actually a little bit more common, is that you have a disease outside of the colon that's pressing on the outside in, and that causes a blockage as well. The really important part that we really want to emphasize for our patients is to say, at diagnosis, we often will ask patients about their bowel movements, about pain, about changes in their bowel movements to try to get an understanding if you're what we call clinically at risk for obstruction. We know, we actually did a study at MSK recently that showed the vast majority of patients, even when their primary is in place, do not get obstructed. But if you do have clinical signs and symptoms of pain that comes and goes, change in your bowel movements, not able to eat, those patients are at higher risk because a lot of the treatments that we have don't really shrink the cancer so well. So in that patient population that have obstructive symptoms, it was as high as 20% of those patients. But the vast majority, if you don't have those symptoms, you don't often get obstruction. So if you had those obstructive symptoms and you only have a primary in place, we highly recommend that they get removed. It's a lot trickier if you have obstructions from a stage 4 setting and it's from tumors in your abdominal cavity pressing, because you could go in and do a surgery and that will beget more problems because that can induce scar tissue and other problems that can lead to more obstructions down the road. And our data showed that as well. So in summary, it's not so common, but if you did have symptoms of pain and you have that primary in place, you want to make sure you share that with your doc so that they know.
Got it. Thanks, Ruby. Kind of a clarification question from Julie. Is Dr. Reidy seeing patients in the clinic or is she just administration as of now?
So I am definitely seeing patients in the clinic, and I would be very honored to care for anyone that lives around this area, and or I still have my my New York license, and we'll be doing telehealth there too.
Nice.
And New Jersey. So for those that may be on the call. So I do have an administrative responsibility, but I'm really hoping and expecting to build the neuroendocrine program. The clinic is where I really have my heart for sure. So I don't think I can ever give up clinical care.
Gotcha. Thanks, Julie. And also shout out to everybody like Julie over on YouTube. That community continues to grow. We are streaming to Facebook and YouTube simultaneously. So I love to see those numbers growing every week. Appreciate you being here. Next question comes from Jack. Do you prefer CT or MRI scans and why?
Great question, Jack. So, I think that very importantly, as I said on these lunches before, we always have to compare the apples to the apples. So the one modality that we choose, we want to make sure we're consistent with it and stay with it. I think that if patients don't have claustrophobia and they're comfortable with an MRI, MRI is probably a little safer because it doesn't have the radiation. But CT liver triphasic can be very helpful, particularly in the lung. MRI, if you're looking at lung because of motion, is not so good. So if you're looking at the chest and you want to get a good look at the lung, a CT is a little better there. If you're just going once a year, it needs to be CT liver triphasic, as you all know, as opposed to just a regular CT. So I'm actually okay with that too. It's just if you're doing scans like every 3 to 4 months, we've been more recently moving more towards MRI just to avoid that radiation.
Got it. Thanks for your question. From Mary Elizabeth, how do you decide between liver embolization and something else like Afinitor to treat liver tumors that are growing?
That's a great question. So there's a couple of things we use to better understand what types of treatment we should be using. If it's only in the liver that the disease is growing, we have to ask ourselves, like what we call, how high is the burden of disease? If there's a lot of tumors, embolization could be a really hard thing for patients to undergo. If there's not a high burden of disease, and it's very hard to know exactly what that means. Some people use 50% of liver involvement. Some people use a little bit higher. But in general, if it's liver only and it's not high burden of disease, we often will employ the embolization because you could do one side of the liver, you do the other side. And then our data and others suggest that that probably controls the cancer for at least a year, if not longer, depending on the type of grade of the tumor. But if you can keep it controlled for that long without the day-to-day side effects of medications, it could be a quality of life issue for patients that could be helpful. So you don't have to then worry about the potential grade 1 to 2 fatigue, nausea, diarrhea, or other things that can happen, for example, with a drug like Afinitor. Now, some people are on Afinitor and they don't have any problems. Some people can get those mouth sores and the fatigue. And so again, I'm always trying to think about the patient's quality of life when I choose these. But I think liver only with lower burden of disease, we would often try to consider embolization before a drug like Afinitor. The exception to that is if it's not just liver only, like if it's growing in a couple places outside the liver, then you want to go for a drug that can go everywhere and kind of take care of the cancer. So Afinitor would be a terrific idea.
Gotcha. Thank you. And thanks, Mary Elizabeth, for your question. Let me know if you have any more. By the way, the Duke reference is already working. Maria says, I'm from Virginia. Duke is within driving distance. So we may have we may have got a new visitor. Laurie says, what are the latest and or most promising treatments for lung nets?
That's a great question. So lung nets are a little bit tricky because sometimes they're PET positive or PET dotatate positive, so that you can use octreotide or lanreotide and or Lutathera, and new studies that are actually enrolling for Lutathera, and sometimes they're not. When they're not PET positive, we're a little bit more limited on what treatment options we have. But I think for those that are PET positive, octreotide or lanreotide, we did that study, is helpful as a first-line therapy, particularly if it's making hormone, because you want to be on that to control the symptoms. And then Lutathera and or other trials that we have on radioligand therapy, meaning radiation attached octreotide or lanreotide. So there's a big study that Tom Hope is doing on testing the role of Lutathera in lung nets, because we really haven't tested the efficacy to know for sure how well it works, and if so, for how long. So I encourage anyone that has PET positive lung net to consider that trial. And then we have other therapies. So what if you're either PET negative or you don't want to go on to Lutathera? So cabozantinib, based on the recent cabinet study, was positive, and it worked well, close to a year for patients with lung net. So I use cabozantinib a lot in patients that have disease progression in lung net. I think Afinitor is a great drug for that. And then the traditional chemos that we think don't work as well, for example, in small bowel net, actually can and do work well for lung net. So drugs like, for example, temozolomide, which is an oral chemotherapy with capecitabine, can be very helpful for lung net as well. So I think we're all looking to see, like, what are the next therapies. Immunotherapy, for example, hasn't been as helpful in our disease as we would like, but the rare responses that we saw were actually in lung net. So that may also be something that you want to discuss with your doctor about considering that, depending on the grade of the lung net that you have.
Got it. Thanks, Lori. Sticking with lung nets, Valerie says, if a newly diagnosed lung carcinoid patient has biopsy results that have shown both typical and atypical cells, what are the next steps to take or additional tests to inquire about?
So the next test would be the PET dotatate scan, because you want to see if it's positive or not. That has two things that it can help us with. We call prognostic. So if it's PET positive, those tumors tend to behave a little bit better and would tend to behave a little bit more like the typical net. If it were PET negative, then that tends to be a biology where the cancer cells may be growing a little bit faster, and that's why they actually, if they're growing a little faster, they can kind of lose those receptors. They're kind of a little bit more immature, and so that test can really help us on how worried should we be about those cells. Are they a little bit more than atypical? And then we would often consider other therapies like the chemo or the targeted therapies I discussed.
Got it. Thanks, Valerie. Chris says, 2 years ago, I had a thymic gland neuroendocrine tumor. The question is, does this cancer come back? Which I know is a big and kind of vague question, but maybe we can just talk about how common recurrence might be, or what else Chris should be considering.
Yeah, that's a great question. Thymic is pretty uncommon. We kind of think they behave similarly to the lung nets, and so we can have sort of typical thymus where they are not as higher grade, and then some of the thymic nets can be a little bit more intermediate grade or higher grade that we get a little bit more worried about. So similar to other neuroendocrines, we do ask the question of what was the grade of the tumor. For those that may not have been on this call before, we ask the grade of the tumor is a number from 1 to 100. Less than 3 is considered low grade. 3 to 20 is considered intermediate grade, and 20 to 100 is considered high grade. And so not surprisingly, the higher grade of the tumor, the more worried we are that it may behave potentially with a little bit more fast growing or more aggressive type of nature. Not always, but we worry about higher grade tumors being a little bit less well behaved, if you will. And so the typical lung thymic nets do very, very well. The atypical ones have a little bit of a higher risk of recurrence. So I would ask your doctor what type of tumor you had, and also size matters, and if the lymph nodes were involved. So those are the questions I would ask your doctor on, what your risk would be.
Got it. Hey, thanks, Chris.
Thanks, Chris.
Next question from Suze. Had a Whipple in 2021 for PNET and recently had gallium-68 test, and it showed lesions on the liver that weren't showing on the MRI, and I was told that was normal. Told by a different doctor I have NET cancer, but baby size. Just watch and follow up in 6 months. The issue is for Suze is this is a mixed message, which this happens often. So her question is, should I wait and watch or get a third opinion perhaps?
Yeah. So this is a really important question and something that our patients struggle with a lot, because just the emotional roller coaster on, do I have cancer?
Totally.
Do I not have cancer?
Totally.
Like, how can you not know? And why would we just wait and watch anyway? And
Yep.
I try to share with my patients the reasoning for watching and waiting. So I think the PET dotatate scans are picking up more disease than we haven't seen in the past, but they do have false positives. So it's not perfect. Like there's definitely times where something lights up and it's not disease. And then there's some times that it is real that we couldn't see appropriately on MR or CT. I will say that many times MR does pick it up. So if there's truly discordance between the MR and a PET scan, unless the MR wasn't great quality, I would question if it were real or not. I think, though, very importantly, when we say you do or you do not have baby cancer and let's just watch it, I think what we're really trying to say is if there are tumors there and if they are so small, it's very hard to get a biopsy. And the test of time can really help us better understand what, if anything, it is, and then the pace of the disease. So it's not that we're saying, go back, don't worry about it, or
Totally.
saying that there's a real good chance it could be nothing, but that the biopsy probably has low utility, because when it's so small and you can only see it on PET, it's almost impossible to biopsy. And then importantly, and most importantly, I would say, because our disease, thank heavens, grows so much slower than other cancers, it might be that those things, even if they're real, don't change sometimes for years. So I definitely have patients that have low volume disease, but it's just never changed. And that's reassuring when we see that first scan and say, whatever it is, it hasn't changed.
Yeah.
So I think that what you're saying is really important, and that the delivery from docs sometimes is different, right? Some be like, yeah, it is, or no, it's not, or maybe
Yeah.
the reality is we're sort of saying we're not sure because these tests aren't perfect. So it could be that the test was imperfect and was what we call false positive, where it's not disease. It could be very small disease that it's too small to even biopsy. So the test of time can help us kind of declare what, if anything, it is.
Yeah, this is such a great point. We get this question all the time, and I really appreciate the care and thoughtfulness you put in that response. I think it's very helpful because it's not just apathy, right?
Yeah.
It's not just like, might be, who knows?
Right.
Yeah, and that's how it's perceived sometimes because people are scared, they're confused, and they want answers, right? They want to, what'd you say earlier? They want a plan. And they are erring on the side of action. Look, if something's going on, I want to be proactive and respond to it. And that's how they can feel when someone says something like that. I think it's such a great explanation of why wait and see is not just meh, but rather like, no, that is more helpful in our journey to diagnosis. Right. And folks, I also want to reiterate that this is exactly why, not to like toot our own horn, but exactly why exchanging in these types of programs with other NET patients is so important, because then you hear someone else say, hey, I had the same thing, ... right? So just that empathy and understanding helps us calm down a little bit. Sorry for using that expression, but just, relax those nerves so that we can, go about the right plan. So yeah, it is a very common issue, and it's always important for me to ask that question because I know it's something our patients struggle with.
Yeah, and I just wanted to add to that, Ring, because I think you said that beautifully.
Thank you.
I always want our patients to be reassured that, like, whatever that thing is, again, if it's real, it will declare itself, but we're not going to miss a window. Like with our disease, it's not like, what if I had biopsied it at that time? It's not going to necessarily mean that we just compromise, God forbid, your safety or your outcome or anything like that, because in our disease, the test of time can be very, very helpful for us. And we're not, again, missing an opportunity to cure something that we wouldn't have otherwise.
Well said. Well said. Folks, if you joined us a little bit later or just joining us, this is Luncheon with the Experts. We're here with Dr. Diane Reidy-Lagunes, formerly of Memorial Sloan Kettering, now of Duke University, right up the road from me here in Durham, North Carolina. We always have folks in North Carolina too in the comment section. So special love to all of those. No bias, no bias. Let's keep going. We have a lot of lung net questions today, so I've got one queued up. We're going to keep staying in that theme, it seems. Stephanie says, I have neuroendocrine lung cancer that spread to the lymph nodes and pericardium. Had surgery, chemo, radiation. And the question is, which is a very common one, should I be seeing a lung cancer oncologist or a neuroendocrine specialist? I can tell you already know where we're going by your smile.
Yeah, this is a tricky one because every institution does it differently.
Right.
So, sometimes in some institutions, it's the lung docs that care for the neuroendocrine cancers. At my old institution and in my current institution, the neuroendocrine experts care for the neuroendocrine cancers. Now, the exception is there are, and we've talked about this on the lunch before, some types of lung neuroendocrine carcinoma, and there's GI neuroendocrine carcinomas that are much more aggressive types of cancers. The lung neuroendocrine carcinoma are thought to be typical lung cancers that have sort of developed another mutation or two and sort of transformed into this neuroendocrine cancer. It's also called large cell or small cell lung cancer. And so those are definitely that's not what we're talking about today. That's a different type of treatment. It's often given with IV intravenous chemotherapies as well as immunotherapies, which can be effective for them. So that's a different type of lung cancer that's almost always treated by the lung specialists.
Got it. Thank you. And appreciate your question, Stephanie. From Jacobs, or perhaps Linda, that might be backwards. How often to get dotatate PET/CT once liver net is stable and not growing and not finding anything new?
Yeah, that's a great question. So this comes up a lot in the NCCN guidelines and a lot of different kind of discussions on how often do you need to get a PET dotatate? And there's another question in here on, talking about radiation, because PET dotatates are definitely more radiation than even a CT. And so I think it really depends on the patient. And so what I mean by that is, for example, if you have known bone metastasis, it's very hard to see bone metastasis sometimes and to get a good understanding of if they're changing or not, because they don't grow by size. You can see a little dot here and there, for example, in the spine. And so a PET dotatate can be very helpful when you have bone metastasis to be able to see if we have new bone metastasis in any place, for example, if it likes to go to the ribs or the skull or the spine. Those are places that, believe it or not, our cancer likes to go sometimes. And so it gives us a clearer picture. But if you have low volume disease or your disease hasn't changed for a long time, I am not of the opinion that you should just randomly get a PET scan once a year. I just think that we should stay consistent with the treatments, with the scans that we do, and not necessarily do additional treatment unless there's a reason for it. So there's always an exception to the rule. But for regular staging, for example, let's say you're on monthly octreotide, your disease hasn't changed. We don't need to, kind of look for a tiny little lesion. You're feeling well. I don't typically just randomly do a PET scan once a year just because. I just stick to what we call cross-sectional, either CT or MRI that I do.
Got you. Thank you. Next question from Jill. What is the best treatment for pheochromocytoma that has spread to bones, lymph nodes, and liver?
Yeah, so that's a great question. I also take care of patients with pheo and paraganglioma. I like to say that they're sort of a cousin of neuroendocrine cancers. And so there's great organizations for pheo and paraganglioma, and they do tend to have a sort of affinity to the bone. And so for a lot of our patients, it can be very hard because if you have spine disease, as many of you may have spine disease, it can be very painful because there's some nerves there. And so we do a lot of types of radiation treatments If it's PET positive, Lutathera or other radio-labeled ligand types of treatments are therapies that we often employ that can be helpful. It used to be MIBG, but that treatment is actually going away. So that's probably going to be replaced by the radio-labeled lutetium-177 dotatate. Cabozantinib was a phase 2 study that was also effective. And we have a study with the NCI of looking at the role of temozolomide, which is effective, plus the drug olaparib, which is another potential treatment option for a clinical trial. So a couple of different types of options for that type of disease.
Got it. Thank you so much for your question. Now it seems we're going to shift to a little bit of PRRT. Effie says, how common, if at all, is edema of the legs post PRRT?
Hi, Effie. That is not so common. I will say, though, that you're bringing up a really good point, that post PRRT, it is common that those cancers can swell. We call that pseudoprogression, right? Because the radiation itself is causing this inflammatory response. So patients can get pain, rarely but seriously. If those tumors are in the abdominal cavity, there's a slight risk of obstruction, because if it grows too much and presses on the bowel, you can be in trouble. And it can cause some lymph node swelling, which can lead to the edema. So it's something that you can certainly see, but I wouldn't say it's a common side effect. Now, the other part of it is with PRRT, there is some steroids that we give to kind of serve as a powerful anti-nausea medication. And so some people can get a little bit of swelling from the steroids, but that's usually temporary. And then you can kind of see that get better pretty quickly.
Got it. Hey, thanks, Effie. From Caroline, as newer types of PRRT are approved, will the use of somatostatin analogs change?
Great question. I love this question. So, the original studies that were done said after PRRT, everybody stayed on somatostatin analogs. And quite frankly, the reason why they did that was because for our patients with hormone symptoms, we wanted to make sure that they stayed on in a safe way, because the somatostatin analog is controlling those hormones. The problem is it's very hard sometimes to know exactly, like on a study, who's having hormone secreting symptoms and not. So they just kept everybody on. And, I think that it's a shot in the bottom once a month, and there is a quality of life issue there. And so for patients that don't have hormone secreting tumors, what is the additive role of keeping somatostatin analogs on when the cancers progress through it, which is why you're on the radio-labeled therapy? We don't know. And so there have been a lot of discussions on potentially posing a study to really ask the question of the incremental value or lack thereof of somatostatin analogs after PRRT, when you've been on it before and it grew through it. But that study design and approval hasn't been happening yet. I will say many of us in my own practice, I do this, that after Lutathera, if your disease has grown on somatostatin analogs and you had a non-hormone secreting tumor, I will have a discussion with my patients to think about dropping it, because I'm not sure how much it adds. If it was only a little bit of growth, sometimes we keep it on. But if it was like real frank disease progression, I don't think that the somatostatin analogs are probably adding too much.
Got it. Thank you. From Jim, Zermello has totally fixed my CSD, carcinoid syndrome. Will it make future PRRT less effective since it blocks the serotonin within the tumor?
Great question. The answer is we don't think so. Carcinoid syndrome diarrhea can be debilitating. I think many of our patients, unfortunately, have multiple reasons for diarrhea. Sometimes they have surgeries. Sometimes the somatostatin analogs in and of itself can cause steatorrhea, which is misinterpreted as carcinoid syndrome diarrhea when it's really just malabsorption. Sometimes it's other therapies that we're using that can cause that problem. So I always encourage patients to, really make sure you explain to us the types of symptoms you can have, so we can better explain it as well, and use appropriate antidiarrheal medications when needed, pancreas enzymes when needed. And sometimes Zermello, when it's carcinoid syndrome diarrhea, can absolutely help in those patients where it's from the serotonin. Lutathera and radio-labeled therapies work a little bit different than serotonin. What it does is it binds to the somatostatin receptor. So it's like a lock and a key. So serotonin is a hormone that just gets secreted into the blood. But PRRT works by binding to a receptor on the outside of the cancer cell. Then when it binds, it actually internalizes the radiation, it zaps the cancer, and it kills it. So being on Zermelo should not affect that whole process, and that it should still work quite well.
Lovely, lovely. Thanks, Jem, for your question. Jack asks, histotripsy versus embolization for liver tumors. And I think it also gives us an opportunity to kind of expand on histotripsy a little bit if you're willing, because people ask about it quite a bit.
Yeah. So the new kid on the block, the histotripsy, I am all for. I don't want anybody to ever think otherwise. Like, I want to do what is always best for our patient. And when innovation comes up, we're like, bring it on.
Right.
Let's test it. Let's study it. And then let's bring it to our patients if it's safe and if it works. We all deserve that, right? So it is not okay to bring a test or a treatment that hasn't been readily tested and that we don't know how efficacious it is or how safe it is just because. So that there's a little bit of a difference in terms of, and I think this is important, what an FDA approval for a device is versus a drug. So, when we talk about PRRT and Zermelo and all these things, there was big, rigorous studies that were testing its efficacy and its safety before we gave it to our patient. The problem with histotripsy is we have not really done that in terms of showing how well does it work for neuroendocrine malignancies and how safe is it? And I think we all have this idea that it's like going to be done on the outpatient and it's going to be easy peasy. It's a lot on our patients. And it's a long procedure. It can be painful. And we really have no great data right now that it's any better at all than embolization. So I think I would love to study it in the context of a clinical trial. Before I left MSK, we were sort of getting towards that. In NYU, they have been doing some work on studying it. And honestly, so far, the jury's not out and it didn't look great. So I would caution anybody, if you need a liver-directed approach, the embolization is the way to go today. It may be later on, we'll learn more about it, but I am not a fan.
Copy that. Loud and clear. Thanks, Jack, for your question. Question from Christina. What's the difference between PRRT and PRLT, which I'm unfamiliar with that? Do I have to visit an endocrinologist after PRRT with Lutathera?
PRLT. Liver treatment, maybe?
I'm not sure. Christina, if you could clarify for us, could also be a typo that happens sometimes, but yeah, it caught me off guard, so I wasn't sure if I just missed something. I am not an expert.
No. Okay. We did have a study at MSK where we gave PRRT to the liver. So it was like only to the liver in hopes to sort of minimize the side effects of systemic, but that's not considered a standard treatment.
Yeah. Yeah, let me know, Christina, if you could clarify. The second question, though, maybe we can address, which is, do I have to visit an endocrinologist after PRRT with Lutathera?
No. Yeah. So, I think that sometimes after Lutathera, if you have a hormone-secreting tumor, we have seen patients where all of a sudden you get the PRRT and the hormone that the tumor was secreting gets sort of shed in overdrive. And it can kind of potentially cause like a serious situation. So we have to give extra octreotide in those patients. It's rare that can happen, but it can, in that rare population, be a little bit scary depending on the hormone that's being made. But generally, the endocrinologist there's not an increased need for endocrinologists after PRRT.
Okay, gotcha. Thanks for your question. Do let me know if you have any clarification on that. Special shout out to Teresa, who is also glad you're at Duke because she is in Eastern North Carolina, which is where I am from originally. So special love to Teresa. Again, no bias. I am from Little Washington, born and raised, Teresa. So that's probably somewhere close to you if you're from Eastern North Carolina. Okay, let's keep it moving. From Valerie, how do you interpret the KI score, and what is the significance of that particular score or a particular score?
Yeah, so I alluded to this before. So a Ki-67 score is a score that our pathologists actually do for us based on what the cells look like under the microscope. So it's actually a stain that they do, and they measure the amount of stain on the biopsy under it, and then they give us a number from 1 to 100. And the higher the stain or the higher the number of Ki-67 suggests that that tumor may be more actively dividing, and so it has a higher grade of the tumor. So again, we sort of said less than 3 for Ki-67 is considered low grade. The stain is probably low. It's not very bright. 3 to 10 is considered intermediate grade, and then 3 to 20, and then greater than 20 is considered high grade. So it goes all the way up to 100. So it's a pathology score that they give us.
There you go. Speaking of something else that you alluded to earlier, Julie says you spoke of lessening radiation. We were talking about scans earlier. Do you usually order the PET-CT dotatate for annual maintenance with a full CT or one with no contrast?
So again, I don't typically do annual maintenance just because, but in patients that need a PET-CT, there are 2 ways to do it. Sometimes patients do PET-CT plus CT liver triphasic all at the same time. And that's fine. I just don't think you necessarily need that every single time if you're getting treatments like, scans every 3 to 4 months or every 6 months. I think you could do one or the other.
Got it. And from Pat, hey Pat, would a PET FDG be helpful for monitoring potential lung metastases?
Yeah, so for PET dotatate negative lung nets, often we will consider PET FDG as another type of PET scan to look at the extent of disease, particularly again if you have bone metastasis. But good quality CT is a little bit less radiation, and it would be just as good if there's no if we don't need to only follow bone metastasis.
Got it. The folks at NCF on the back end said watch and learn versus watch and wait, referencing what we were talking about earlier. I think that's a really cool way to reframe it.
Watch and learn versus watch and wait. Exactly.
Yep.
I love that. We're going to watch and learn. That's exactly
well
right.
said. Well said. From Lori, can you address the recent personalized care for lung net patients study conducted by Dr. Dirks and how long before it's available for widespread use? I'm not familiar with that study.
Sorry, it was called personalized care?
Unlocking personalized treatment for lung neuroendocrine tumors.
Oh, this is a sort of precision medicine with NetRF. Yes. Yeah, so I think that many of you know NetRF is a wonderful organization that really focuses on the science. And he had a study where they are looking at this sort of, we talked about this earlier, the typical versus the atypical neuroendocrine, and then used biomarkers to see how they can differentiate the two. And then importantly, were there biomarkers to then help us therapeutically choose what's the right treatment for our patients. So one of the things I didn't discuss before, but I'm really glad that you brought this question up, is the role of something called DLL3. So in neuroendocrine cancers, actually, Dr. Thumalapalli, who's my partner at MSK and my mentee, he's doing a lot of work on this, as is other folks. But what they're doing is they're looking at some of the higher grade tumors, including the lung nets, as well as pancreatic neuroendocrine tumors and some colon and other GI nets as well. The presence of DLL3 on the tumor, which is a pathology test that you can order, or your doctors can order, could open up therapeutic options for treatments that target the DLL3 in a radioligand perspective, and also what we call BiTE therapy, where a DLL3 molecule is actually attached to a little bit of chemotherapy, and then you can get that treatment by IV. It's a little bit harder on the patients. In fact, you have to be in the hospital for a night just to make sure that you don't get like an inflammatory reaction. But DLL3 is a new biomarker that we're very, very excited about, and that study was also looking at that.
Got it. Thank you. From Grace, hey Grace, good to see you. In the face of too many metastases and the concerns of liver failure in the case of progression, is waiting and scanning often, like 3 times a year, more beneficial than moving to PRRT? The disease has been stable for years, but the volume in the liver is too large. You follow that?
Yeah.
Okay.
That one may be a little bit hard for me to answer without seeing the scans and the numbers and all that kind of stuff. I will say that if something is stable, that's wonderful. I think academic centers will often give PRRT in a patient that has high burden of disease in the liver if it's growing or we think that the burden of disease is high enough. So I would not say that high burden of disease is a reason to never give PRRT. So I would say maybe getting an opinion at an academic center if they haven't already would be helpful.
Got it. Thanks, Grace. Please let me know if you have another question. Tony says, my net resulted in my lower lobe left lung being removed. The cancer metastasized twice, 3 years apart to my sacrum. I was radiated. His question is there a limit to how many times I can be radiated?
There's a limit of how many times you can be radiated in the same place. So you often get re-radiation with some sensitive types of radiation, and sometimes even the new type of radiation called proton therapy can be used to re-radiate an area without causing sort of tissue damage and what we call necrosis. But if it, heaven forbid, popped up in another place, it would be very safe to irradiate that new place. But re-radiating a site can often cause damage to the normal tissue and can cause fractures and other things. So we just have to be mindful and careful about that.
All right. Thanks, Tony. From Teresa, do you have any preference for administration of octreotide in either the bottom or in the hip?
Oh, that is a great question. So recently, a few academic institutions, including my old one, changed the way we administered that injection. It was a nursing practice that the nursing guidelines, I think nationally, said the buttocks has a high rate of sciatica and hitting that sciatic nerve, which for those that may have had that happen, it is terribly painful. So even though we know where to go and try to avoid the sciatic nerve by going to the apparatic quadrant, we were still seeing patients that had the sort of traditional pain down the back because of sciatic types of problems because we hit the nerve. So the Nursing Society recommended moving over to the hip. It's much safer for the patient. It's been a little bit of a mixed bag in terms of what patient preference is. So I think the jury's a little bit more out in terms of the quality of life of one location versus the other. But certainly from a safety perspective, the hip seems to be a little bit safer according to the nursing guidelines.
Got it. Thanks, Teresa. From Yara. Yara says, hello, could a dose of 2.5 milligrams of everolimus or everolimus be effective for neuroendocrine tumor with METs in the liver? And what's the minimum effective dose?
Sorry, can you say that one more time, Rain? I was just reading another picture.
No worries. Could a dose of 2.5 milligrams of everolimus be effective for a NET with METs in the liver? And what's the minimum effective dose?
I don't think so it's a great question because I think it is important for our patients to understand how we get to dosing to know what's the effective dose. We actually don't test drugs that way. We go the other way and we say, what is the highest dose that won't hurt patients? And so we really don't know in any one patient what's the minimal effective dose that we need, but we know what the maximal safety dose is. So for example, 10 milligrams based on the early studies was as high as you would go for everolimus. For some patients, that's still way too high. And so many of us moved over to the 7.5 milligrams because the 10 milligrams is more toxic than the 7.5, but we don't have great studies to say, okay, but how low can you go? Can you do every other day? And so it does come down to the patient's quality of life. And I would say if you can't tolerate 5 milligrams and the scan shows stability on 2.5 milligrams, I would keep going.
All right. Thanks, Yara. From Valerie, for a newly diagnosed lung carcinoid individual, what tests should be considered to determine which hormone is being expressed? Is cortisol one potential hormone if intractable weight gain?
Yeah, so the two hormones you worry about for lung NET is serotonin, which is the carcinoid syndrome, and actually the hormone that lung can make is something called ACTH. ACTH triggers the adrenal gland to make cortisol. So we would check the ACTH to make sure that that's not being secreted in some patients that are symptomatic. But the NCCN guidelines are really the symptoms drive the hormone marker, because sometimes these hormone levels can be a little bit off and you don't have the hormone level, like sometimes a little bit of false positive. So we do want to ask really important questions on sort of any types of symptoms. So any swelling, fatigue, nausea, lowering of the electrolytes, those are things that we think about ACTH that can cause an elevated cortisol. I got that. Yeah. So peptide receptor ligand therapy is the same as PRRT. Yeah.
Oh, okay. Copy that. Yeah. Okay. I haven't gotten there yet. Yeah. Thank you. Glad we cleared that up because I was also confused.
Yeah.
From Melissa, have you begun assembling a net focused team at Duke, including surgeons, interventional radiology folks, NM, imaging, et cetera, et cetera?
Yeah, so there's actually a neuroendocrine tumor team here. Dr. Mike Morse is a neuroendocrine specialist for many years and practices here. And there are several surgeons that do liver surgery and neuroendocrine tumors when appropriate. So Dr. Peter Allen and I were actually partners together in MSK. He came down here in 2018. He's actually one of the reasons why I'm here now. He does neuroendocrine. Dr. Mike Litsky also trained at MSK and is down here. There's another Dr. Trey who does small bowel neuroendocrine and is terrific in both DUH as well as in Raleigh. So we have a good team, and the interventional radiology team is great as well.
Nice. Kathleen is also moving to Durham next week. Look, everybody's coming here. Question for you. I know we're not New York, but there is quite a good amount of culture here and quite a great cuisine scene. Is there a favorite restaurant that you've eaten at?
Absolutely.
Yeah, let's hear it.
So I'm going to say there's two. They're right next door to each other, and they're actually close to my apartment, which is great. So I love Local 22 and Paris God.
Yeah,
Paris kind of the fancy one, but Local 22 is like good food.
Parazad. So Giorgio, who owns Parazad, is like one of our local restaurateurs, and all of his restaurants are incredible. He's one of the faces around the triangle. But yeah, Parazad is legit. Try Nana's whenever you get a chance.
I love Nana's too.
Okay, yeah, Nana's.
Yeah, and Nana's steak too. I love.
There you go. You're local already. I love it.
I'm getting into it. I'm a New Yorker, so I love the restaurant.
But don't overlook the lowbrow, barbecue options and things like that, because they're just as good.
I would never overlook them.
Let's see. From Melissa, do you favor some conventional imaging during PRRT, and do you use SPECT CT during treatment at intervals following treatment, rather?
Melissa, great question. So the reason why we don't like to do regular conventional treatment during PRRT is because of what we kind of briefly discussed before, which is to say these tumors do swell during PRRT. So they get bigger before they get smaller. So we would never, ever want to do a scan that shows, it's bigger in the absence of symptoms or other things. And then we're kind of confusing ourselves. And then after the third or fourth treatment, it starts to shrink again and we're doing fine. So I think the sort of jury verdict was don't do scans unless you're symptomatic and not feeling well. So we definitely have patients, unfortunately, like it doesn't work for everyone. And so it's a minority of patients, but if patients are losing weight or starting to develop, God forbid, like ascites, fluid in the belly, or they have increasing pain and they're just not doing well, or they have really bad reaction, then we will absolutely get scans, and you should get scans and be an advocate to ask your doctor for scans if something's not right. I mean, the hope and expectation is the first round is a little bit hard sometimes, but then by the second round, you should be feeling much better because it should start to, attack the cancer, and so that you can get your energy back.
Got it. Thank you for your question, Melissa. Moving on, and folks, we've got just about 5 minutes. We're going to try to get as many more as we can. Susan says, what size PNET in the body / tail is considered too small to biopsy?
I don't know if there's a magic number on too small. Those that are a couple of millimeters, I think it would be kind of hard to get a needle in there. Although, depending on the endoscopist, sometimes it can be just 3 or 4 millimeters. The bigger question is why, and the rare but very serious risk of pancreatitis. So the pancreas is just, it's not a forgiving organ. It doesn't like us to be anywhere near it. It doesn't. The liver, you can take out a big chunk of liver, the next day it'll grow back. The pancreas doesn't grow back. In fact, there's an important question that I'll probably just answer now that when you resect the pancreas, it just doesn't grow back. And so as a result, you no longer have as much insulin. And so you're at much higher risk of developing diabetes because you just don't have the functional pancreas like you had before. So I think it's really, we have to be careful to not just biopsy something, because pancreatitis can be life-threatening, and can be very, very hard on a patient. So the question is more sort of the clinical need to biopsy a very small tumor versus just watching it.
Got it. And Charles, I hope you got that response to your question, Charles, from over there on YouTube. Next one from Eltaz. Bone biopsy was performed recently. Neuroendocrine cells were seen in the sample, which was aspirated. Does it mean that there is a bone metastasis? My primary tumor was in the GI small bowel.
So, and you said biopsy. I'm trying to read the questions.
No, it's okay. Bone biopsy was performed recently, and
Right.
neuroendocrine cells were seen in the sample, which was aspirated. Does that mean there are bone metastases?
Yeah. That means that the neuroendocrine figured out how to get to the bone. Yeah.
Okay. Anything else to consider there, or
Yeah, I mean, look, believe it or not, just because it's there doesn't mean you have to treat it. So I do think we have to be a little bit careful. If it's a big tumor, or if it's symptomatic and it's painful, then we definitely would want to radiate it. You know, again, as we've sort of talked about multiple times, the good news is we have to be mindful and aware that many of us can live many, many, many years with this disease. So we have to be a little bit careful on how aggressive we are on treatment. And radiation can soften the bone a little bit. It's needed most times, and it can actually protect from fractures if there's a lot of tumor there. But we don't just randomly radiate small disease if we don't need to, because we want to keep those bones healthy.
Got it. Thank you. Tom, hey, Tom, how are you? Good to see you. Tom says, what percentage of midguts result in CHD, carcinoid heart disease, resulting severe tricuspid regurgitation requiring valve replacement? So what percentage of midguts result in CHD?
I would say very, very low.
Very low.
Yeah, I've not seen that.
And does your facility have any experience with evoke valve?
Oh, tricuspid regurgitation. I thought you said GERD. I'm sorry.
No. I might have mumbled. Yeah, I am here to be your spirit guide.
You, Nate. I'm sorry. I'm like trying to get all the questions done in 3 minutes. So carcinoid heart is something that is common, and there are several centers that are experts in this. Up in New York City, I worked with Dr. Girardi at Cornell and New York Presbyterian, who has replaced a lot of valves from our patients. And the thing that's a little bit scary about carcinoid heart is we truly don't understand what we call the pathophysiology, like when it can start to occur and why. Because we've had a couple of patients that we were following regularly with, echocardiograms, had shortness of breath, and suddenly their valve is out. So we don't really know the sort of natural history of when it can happen and why. And there is, unfortunately, a risk of it happening again after the valve replacement. Not always. And so, but we do want to ask the question after the valve replacement of, can we start getting some treatment in to allow us to get that hormone level down so that it doesn't happen again.
From Sasheen, small bowel primary nets seem to receive less research. Is that true? And if so, why?
That's a great question. It actually is not true. Almost every clinical trial that we have includes a small bowel net as well as a pancreatic net cohort. The problem is, the good news is small bowel net tends to biologically grow slower than other types of neuroendocrine cancers. The not so good news is that means for some reason it's just a harder nut to crack in terms of what treatment options we have. So we have Lutathera, we have some of Afinitor for the non-functional tumors, but small bowel net, there's just not as many therapies that have been helpful. We've tested them, it's just they're not as efficacious as they are in, for example, pancreatic net.
Got it. Interesting question from Melinda over on YouTube. When my paraganglioma journey started, I was told that it was mainly from Ireland. I've been wondering, is this a culturally biased disease?
We don't believe. Hi, Melinda. That's why I was saying the great question before. It's unclear if sometimes these diseases can be germline, meaning that it can be inherited. And so there's something called SDH, and that may be a mutation that came from Northern European as opposed to Ireland and other things. BRCA is very similar, right? So BRCA, we know, for example, is more in the Ashkenazi Jewish population. So there's a little bit of that in terms of some mutations being genetically from different ancestries, but nothing that we're aware of for neither neuroendocrine nor paraganglioma in sort of environmental cultures that can cause the cancer.
Okie doke. Got it. And folks, that is our show. It is the top of the hour. We got to as many as we could. I think we left a few on the table, but again, I'll reiterate, message ncf.net/support line, or we'll always be back in every 2 weeks, and we'll try to get your question answered then. Dr. Reidy, thank you for being back on the show.
Thank you all. I miss all of you that I do and don't see anymore, but please come to Durham.
It seems like you're going to have a slew of new patients after today's show. And of course, again, welcome to Durham. Folks at home, thank you as well. As always, I hope this program helped answer some of your questions. And finally, my name is Rain Bennett. I have been your host. Thank you for watching. And please join us next time on Luncheon with the Experts. Stay healthy, stay safe.